since I'm streaming from my cell phone, or tethering from my cell phone, I'm gonna turn the video off, um, and maybe until the end we can answer some questions. But thanks for joining me this morning, guys. I think it's really awesome that these things are kind of getting put together. I know it kind of sucks, not being able to actually physically go shadow docs because of obviously the situation we're in right now. So in any case, I think we'll have a good time this morning. I appreciate you guys lending me your ears Saturday morning, and let's get going here. So my name's Andrew Chung. I'm a fellowship trained orthopedic spine surgeon, and we'll kind of talk about what that means here shortly. So I did my undergraduate training or work at Texas Chiropractic College. I actually had a somewhat of an interesting path to medicine. I started out in accounting at the University of Connecticut, and then transferred down to the University of Houston. Really, if I can be honest with you guys, I just didn't really have my act together academically. Didn't really know what I wanted to do. Ultimately, I ended up in a chiropractic college because my dad, he's PM&R, and he worked with a chiropractor. He said, "Hey, you got to do something with your life. Go check out chiropractic school." So I ended up in chiropractic school, and it was there that I really fell in love with the anatomy of the body, and particularly the anatomy of the spine and the musculoskeletal system. I was actually a personal trainer at the time too, and so the musculoskeletal system in general just kind of fascinated me. And so ultimately, while there, I kind of got my act together, or not kind of, I did get my act together academically, and shortly thereafter, once that happened, I applied to medical school, and I went to the Philadelphia College of Osteopathic Medicine. Ended up doing my residency in orthopedic surgery at the Mayo Clinic in Arizona. And then just this past year, I finished my fellowship training in spine surgery at the University of Southern California. And just because I'm a glutton for punishment, and I just can't stop learning, I'm doing an extra 6 months in some advanced techniques of spine surgery at Cedars-Sinai, and then another hospital called Docs with a particular very well-known spine surgeon. So, and after all this, I'm going to head back to Phoenix, Scottsdale area in the new year to start my practice at a private kind of / academic practice called Sonoran Spine. So, beyond that, I am a family man, and I would encourage you guys to, I know the path to medicine is one of significant commitment, and there's a lot of sacrifice. But I would encourage you guys to always kind of make time to kind of do things outside of medicine, and otherwise you're going to end up pretty miserable. But that being said, again, it is a hard road. It takes a lot of dedication. But just remember to kind of always have that little bit of balance. People often ask me, why DO? I think you can probably guess just by my kind of untraditional or non-traditional kind of path to medicine, why I may have considered a DO route. Coming from a chiropractic background, DO schools, at least traditionally in the past, tended to be a little bit more forgiving of grades, meaning the average GPA to get in is just a little bit lower. While I had done really well, I had like a 4.0 my last 50 hours or so, my cumulative GPA, just because my lack of kind of academic direction early on was like a 3.1, I think. So I just kind of given kind of those things, I decided to kind of take the DO route. I also kind of agreed with the philosophy of the osteopathic approach, and so I just gave it a shot, and that was probably the best decision I've ever made. I made some excellent friends there that I still talk to this day, at least weekly, and so and obviously it was the path to getting to where I am now. It enabled me to get to where I am now, and so I wouldn't have it any other way. And at the end of the day, I know right now and kind of the media climate that we're dealing with, there's this talk about, DO versus MD. And I'll tell you, at the end of the day, it really does not matter. The end product is the same. And really the factor that matters most is you. So there are terrible DOs, there's terrible MDs. There's terrible MDs that have trained at the best programs. There are terrible DOs that have trained at the best programs. But on the flip side, there's also awesome DOs and MDs that have trained at, the quote unquote relatively unknown programs. So at the end of the day, the degree doesn't matter a whole lot. The end product is the same. And again, it ultimately is up to you to kind of become the best doctor you can possibly be. So my advice to students is always just kind of get into the best program possible that fits your needs. Now, I will say, just candidly, it does make it a little bit harder if you're, DO, and then certainly harder as an IMG to get into the most competitive specialties versus coming from, a well-known MD program. That being said, it's hard for even the MDs from the best programs to get into some of the most competitive specialties like orthopedics. But at the end of the day, yes, the degree and the institution that you're coming from can at least help you get in the door a little bit easier. But it's not a guaranteed thing. So kind of getting back to my point that ultimately, even that getting into the best programs is ultimately up to you, regardless of what your degree is. So just get into the best program possible that kind of fits your needs, that makes sense for you, and then the rest is kind of in your hands. Another question I often get is, again, orthopedic surgery is quite competitive, and so particularly as a DO, kind of going to the MD side of things, at least in my time lately. In the last year, all the programs have kind of come under one umbrella, and so the residency match process is essentially unified, where before it used to be separate. So DOs would separately apply to DO programs, and then if you wanted to enter into the MD match, you would basically have to elect out of the DO match and go that route. And traditionally for DOs in orthopedic surgery, it's been very difficult. So the question I always get asked is, what did I do to kind of make that happen? It's kind of just, what you would expect. Get the best grades you can, get the best board scores, all that stuff. Just optimize your CV as much as you can. Get involved in research. Letters of recommendation are huge, and this is an entire conversation in itself. But just to kind of keep it brief, letters of recommendation matters to some degree, or to a large degree, I should say, where they're actually coming from. So not to knock the community, doc who's doing excellent work. I mean, I'm going to be a somewhat of a community guy, surgeon, but they're not going to be as well known in the academic community as Dr. Smith from the University of Pennsylvania, right? And so letters of recommendation do matter in terms of where they're coming from and who they're coming from. So like a professor of orthopedics is probably going to be more well known and have more kind of clout than maybe an assistant professor, some young guy like myself. So it's just something to consider down the road, and even for medical school. This may be kind of getting into details that are kind of far in the future, but at the end of the day, just like the interviews for medical school matter, so do interviews for residency. And one of the best ways you can kind of interview is actually going to those places and doing what's called an away rotation. So honestly, this is probably your best kind of way to get your foot into the door of different, quote unquote competitive institutions. So bottom line is, it's doable, but it takes a lot of effort, it takes a lot of commitment. And if orthopedic surgery is something that you want to do, whether you're a DO, MD, or IMG, it's a very competitive specialty, and just be prepared to work hard to get there. And then, again, this might be way too far in the future, but once you get into residency, you're going to essentially get a fellowship for spine. Now, to get the most competitive specialist fellowship, you definitely, again, want to do the best you can to make your CV look as best as possible. So one of the ways you can do that is research, and again, kind of similar concepts here. A lot of recommendation, interviews. So how do you become a spine surgeon? I think people get confused when they hear spine surgeon. In some communities they think neurosurgeon. In other communities they think orthopedic spine surgeon. So who's really the spine surgeon? And the reality is that both are spine surgeons. So if you look at the history of spine surgery, kind of going back to the early 1900s, the spinal fusion work was done by the orthopedic guys. Kind of makes sense because we deal with bones and we deal with putting plates and screws and broken bones and stuff like that, putting hardware around bones. So that's kind of what the orthopedic spine surgeons did, was that they would kind of do the bony work for the spine, and then also deal with spinal deformities. So like you guys may have heard of scoliosis. The orthopedic spine surgeons would kind of deal with that stuff. On the flip side, the neurosurgeons would kind of do the nerve work. So as you guys know, and we'll talk about, the spine has two functions. It kind of keeps us upright, but it also protects the nerves, the spinal cord. And so the neurosurgeons would do, if there was like pinching of nerves and things like that, they would go and do what we call decompression, where they would kind of unpinch the nerves. And oftentimes the orthopedic surgeons and neurosurgeons would work together to kind of, fuse the spine or instrument the spine, and then also, take pressure off nerves, which nowadays, in the last 30 years or so or more, really both specialties do. And in today's kind of era, really there's no difference between the two. The training route is, as you can see here, a little bit different. For orthopedic surgery, we do 5 to 6 years of training, and we learn how to treat every single bone, every single muscle in the body, including the spine. And then we have to do a year of specialized spine fellowship to get the training, the adequate training to be able to go out and do spine surgery. Neurosurgeons, they obviously deal with the brain, but the other thing that they deal with is the spine. And so they, throughout their longer residency, tend to get more spine exposure, just because they're either dealing with one or the other, whereas we're dealing with kind of multiple parts of the body and cover all that. There's just not as much time spent typically on spine alone during our residency. So that's why we end up having to do a spine fellowship. They usually can come out and actually effectively operate as a spine surgeon. But that being said, a lot of hospitals are still requiring neurosurgeons to get spine fellowship training. And so you're looking at a very long road to ultimately become a spine surgeon. Now, there are some differences still. Neurosurgeons tend to do more of the what we call intradural, like tumor work in the spine. So, dealing with tumors of the nerve, spinal cord, things like that. Orthopedic spine surgeons typically just, either don't want to deal with that or don't get the training to do that. And then on the flip side, orthopedic spine surgeons still kind of dominate treating spine deformities for kids. And in terms of adults, I think both are starting to do, neurosurgeons are starting to do more adult deformities. So at the end of the day, again, spine surgeon is a spine surgeon, whether you've gone the neurosurgical route or the orthopedic route. I'm biased, obviously, towards the orthopedic route. think it kind of fits what I wanted more and my personality better. So hopefully that kind of clears things up for you. And if you guys have any more questions about it, I'm happy to answer. So long road. So what do spine surgeons do? We obviously we operate on the spine, but we also manage the non-operative kind of treatment of spine conditions. So on a typical clinic day, I would say on average, 90% of patients you see are not going to require surgery, and probably even more. And you have to think about this because, oftentimes these patients are being sent to spine surgeons because, the primary care doc or whoever referred them, not all are referred, but whoever told them to come to the spine surgeon probably thought that they needed spine surgery. So they've been screened a little bit, meaning spine problems actually don't require surgery. A lot of what we do is kind of help to manage that. And then obviously we do surgery and we treat different conditions of the spine, including arthritis of the neck, back, disc herniations, spinal deformities like you see here. It's called a scoliosis. Kind of see that S-shaped curve. So basically what we're looking at is this is obviously the body, and we're looking at them front on, and you can see this S-shaped curve here. And after putting some rods and screws in there, and probably some other work, you can see that that patient's been straightened out. So that's a spinal deformity surgery there. We deal with trauma of the spine, so broken spine, fix it. And then we deal with tumors, both of the bones in the spine, and then of the nerves and spinal cord. What do I love about spine surgery? I could sit here and talk to you guys all day about this because I love it. Obviously, it took me a while to kind of figure out what I wanted to do, and this is what I stumbled upon, and I absolutely love it. The anatomy is fascinating. You're dealing with some really kind of high value real estate, right? So you make a wrong move during surgery, you can actually paralyze that patient. Or, for instance, what we're looking at here is a CT scan, and here's the bones of the spine. Right up here is actually your aorta and inferior vena cava. There are kind of major blood supplies to the lower extremities, and obviously the vein returns the blood from the legs back to the heart. So when we're doing some hardware work, sometimes what we'll do is we'll put what's called like an inner body right here. What that is this big spacer that kind of goes on top of the body here, and it helps to fuse the spine. It'll make more sense on the anatomy slides, but the point being is you can do that by coming in from the front. You can do it by coming in from here. You can do it from the back. And you can see you're working around some pretty important structures. So you can really damage somebody if you're not very precise in what you're doing. And I find that fascinating, and I find that exciting. It's something that, obviously kind of, I'm passionate about, right? So for me, even just the anatomy is fascinating, and really just gets me up in the morning and gets me excited about what we're able to do. Clinic is cool. Most surgeons don't like clinic, but for me, if I'm going to be in clinic, I want to be in a clinic that's going to challenge me. Spine patients are oftentimes a diagnostic challenge. There's a lot of reasons why people can have, hip, knee, ankle pain, arm pain, wrist pain, finger pain, just in the extremities themselves. But as you guys may already know, if you have a pinched nerve in the neck or the back, that can also cause pain down the arm or the leg. And so, sometimes we got to figure out, hey, is this really the spine or is this something else? And, x-rays and MRIs, all these imaging studies are great, but as you guys will probably learn as you go through, your careers, is that they don't tell the whole story. And just like cars, if they've been driven long enough, kind of break down with time, even though they are driving just fine. Like if you take a car that's been driven for 5-6 years, you take it to the mechanic, they're going to find something that's a little, rusted or broken down. It's the same thing with imaging studies. So you get an x-ray of anybody over the age of 20, they're going to have arthritis, right? They're going to have some degree of arthritis. You get to the age of 65, over 65, 70% of people are going to have evidence of arthritis. And these people may have no pain. And so, again, the x-rays don't tell the whole story. And so you really have to be good at being a good diagnostician in the clinic, which I find, again, fascinating. If I'm going to be in clinic, I want to be challenged. And I think as a spine surgeon, you have that opportunity. Obviously, you guys are going to see some pictures here, but surgery is so cool. Again, you're dealing with some fascinating anatomy, and we get to use some really cool tools, and there's just a lot of awesome stuff we can do in spine. That's very exciting, and the technology just keeps getting better and better. So here's a little video of a robot arm that I've been working with at Cedars. That the idea here is that it kind of helps us place screws into the spine, and it kind of takes out the human error. So you get to play with things like this, and again, it's just cool stuff. And so technology keeps getting better and better. Our understanding of spine is still not that great, which is exciting because it means that we still have so much to discover about the spine. And so the future to me is very bright. Spine surgery is always going to be interesting because we're always learning. And anyway, I could sit here and talk to you guys all day about why I love spine, but hopefully that gives you an idea. I'm not going to belabor this. Really, the weekly schedule for a spine surgeon is variable. As a surgeon, unless you're employed by the hospital and the hospital tells you exactly what to do, as a surgeon, typically you kind of make your own schedule a little bit. So it'll typically consist of some sort of combination of days in the operating room with clinic days, and then weekends. Typically you're rounding on patients if you have them in the hospital. And what I mean by that is you got to go see them, make sure they're doing okay, and so on and so forth. Some people will take call. I won't be, but some people will take call, and certainly throughout residency I took call, and basically what that means is if a hospital that you're working at has an emergency department or trauma, as a trauma center, if somebody comes in that injured their spine or has a problem that needs to be fixed, and you're on call, you're in charge of taking care of that. That can happen anytime during the day or night. So that's what call is. As a surgeon, you typically don't have the next day off. So if you're on call, it can be tiring if that's something that you end up doing. So I wanted to give you guys just a look inside the OR. This is typical OR. Hopefully you guys can see my mouse here. I'm just going to point a few things out that we kind of use. Obviously, here's the patient. He's in a prone position, meaning he's face down. And then, this stuff right here, it's called a bear hugger. Basically keeps the patient warm. Anesthesia's up here. You can kind of see the tube going to his endotracheal tube, which basically, with anesthesia, the patients are essentially, for lack of a better word, they're essentially dead, right? You actually induce them to almost be dead, and you're actually ventilating for them. So you're actually breathing for them. So that's what that tube's for. It's what's called a C-arm. It's basically an X-ray, intraoperative X-ray that allows us to kind of figure out where we are in the spine. And then some of these monitors allow us to kind of actually see that. This is a robot attachment. That's me talking to one of the other surgeons. There's a medical student right there. This is a circulating nurse. Kind of just make sure everything's running smoothly in the OR. So now what's happening here is that they're prepping the patient. So obviously, we don't do surgery in our garage for a reason, right? We're trying to minimize any infection. So that's why we do it in a very sterile environment. And what she's about to do right now is basically clean the skin with a antiseptic called chlorhexidine. Here's a robot kind of console, and you can see that this representative robot kind of representative is kind of loading some software that we can see. So what we've actually done is pre-planned the instruments or the hardware that we're going to place into the spine, and that's what she's pulling up there. Anytime you go into the OR, you have to clean your hands, and so you got to scrub. Traditionally, that's you do it with a soapy brush. You scrub for about 2 minutes to really get those hands nice and clean. Or there's a gel that you can just use to kind of disinfect your hands, but we do this every single time. In spine, sometimes we're working through pretty small incisions, dark holes, and so we need a headlamp. And then obviously you can see I'm using loops, what are called surgical loops there. These aren't normal glasses. They allow for some magnification. This is just a couple pictures of the robot in action. Again, just look at the stuff that we get to use in orthopedics, and then in spine. We get to literally drill holes into the spine. I mean, if that's not cool, like I don't know what is. So it's exciting. And just to kind of forewarn you guys, I'll let you guys know, but there will be some pictures of blood and stuff like that coming up. So if you've got a problem with looking at blood, just look the other way. So instead of loops, sometimes we'll use an operating microscope, which allows for very fine magnification and very intricate detail of kind of what we're working on. So particularly when we're working around nerves, you really want to know where you're at. You really want to be close up, so you know that you're not inadvertently damaging something when you're doing your work. This is just showing you there's other tools too. So instead of robot, what's often been used is intraoperative navigation. So it's basically computer navigation to kind of help you put screws in. Traditionally, basically the way that we, and we still do, and I did a lot of this during residency. We would just put screws into the spine. We would do a lot of things just kind of without these technologies, but the technologies are cool. They can certainly help. And so I'm just kind of showing you what's all there. I guess if you've never been in an OR, I should kind of point out what's happening here. So I'm obviously gowned, right? So we've got gowns on, we've got gloves on to kind of keep things sterile. This is what's called a bovie here. It allows us to cut through tissue, but it also cauterizes it, so there's no bleeding. If we just use a scalpel, a knife to go through all the skin and muscle and so on and so forth, there'd be a lot of bleeding. So that's why we use electrocautery, what we call the bovie. This is a drill, so we use that to actually drill away bone to get to oftentimes the nerves that are encased in the spine. Just want to show you. So what we've done in this picture to the left is we've done a surgery through these small tubes. My mentor there was working through his side, I was working through my side, and you can see how small that tube is. And I just kind of want to show you another reason why spine surgery is so fascinating to me. In one picture you see me drilling into the spine with these big power tools, and in here you're kind of seeing how delicate you have to be in particular when you're doing these kind of small, what we call minimally invasive techniques. You really don't have much room to work within, and so you really have to be very precise as well. So again, that's what I love about spine, is that it does take a significant amount of finesse, but it does take strength too. So it's kind of you got to have that balance. So let's briefly talk about spine anatomy. I don't want to get into the weeds here too much, but I do want to at least give you a general kind of understanding. And it sounds like you guys are pretty savvy, so you guys already know all this. So I'm gonna just kind of breeze through this. So as we know, the function of the spine really is to keep us upright, right? So we're not worms. and then it protects the nerve element. So, you know, what I mean by that is obviously we've got a brain, and then we've got a spinal cord that extends down from the brain, and then from that comes all the nerves that control our arms and our legs, and the spine protects all of that. So that is just kind of showing you that. So brain, spinal cord, in the neck region, and then all these nerves that, you know, come off and control our arms, and control our legs, bowel and bladder function, so on and so forth. We have 4 distinct curvatures in the spine by the time we're adult. If all things are normal. So we have what's called a cervical lordosis, cervical meaning neck, and it bends backwards, so that's the lordosis. And then we have a lumbar lordosis, lumbar meaning low back, and it bends backwards. And then we have a thoracic, what we call kyphosis, where you're kind of bending forward here, and then the sacrum will also do that as well. And this is just a consequence of, as we start to sit up as babies and stand, the spine will naturally kind of take on these curvatures. So when you hear lordosis, kyphosis, we all have those curves in our spine. But you know, oftentimes if they get accentuated, meaning they're too big, the curves are too big, then that can become a problem, and that can actually be a significant difference for some people. You look at just the general structure of a vertebrae just meaning, you know, one of those segments in the spine. You got a body up here, you got these stout kind of pillars of bone called pedicles, and then you've got all these little kind of processes back here. A process is basically just like an extension of bone where muscle is attached to. So we have these kind of all over the body. Spinous process, so if you feel your back and you kind of feel that you know, kind of backbone, that's what you're feeling is the spinous process. And all this other stuff is much deeper. There's a bunch of muscles here, a bunch of soft tissue, and so you can't really get down to some of the stuff down here just by feeling. So if you're feeling anything in the spine, it's usually the spinous process, and we actually use that to kind of figure out, without, you know, any sort of X-ray, kind of where we're at. Intervertebral discs, they form 25% of the height of the spinal column, and you can think of these things as like shock absorbers. They're almost like kind of jelly donuts. So the outsides are firm, the insides are soft. The insides are made up about of 80 to 90% water. We call that inside the nucleus pulposus, and that's what allows for kind of the shock absorption ability of the spine. So your spine isn't stiff; it actually gives. And in fact, kind of a fun fact is that because these things are water filled, these discs, as you kind of stand throughout the day, the water actually diffuses out into the surrounding bones. And so if you measure yourself at the end of the day after a long day of standing, you're actually going to be shorter than when you what you started out as in the morning. So this kind of sucks for me because I'm not that tall. But you know, luckily when you lay down and you go to sleep, you know, the discs kind of reinflate throughout the night. They get rehydrated. So in the morning, you're kind of back to normal. So when we talk about arthritis, just a kind of little segue here, or a little clinical point here, is when we talk about arthritis in the spine, what we're really talking about is the disc wearing out. And this inevitably happens in everybody. So if you live long enough, your discs are going to wear out. Just like the cartilage in your joints, your hip, knee, you know, they all wear out with time. This is kind of the equivalent of arthritis in the spine, is that the discs actually kind of dry out and wear down, and as a result of that, you get kind of all this other stuff that follows. This is a cross section of a disc, just, you know, under microscopy, so you can kind of see that, you know, this kind of outer, what we call annulus, is, you know, looks nice and kind of robust, and then in the inside you've got this void here, probably because the water's all dried out, but kind of gelatinous material in the middle called the nucleus pulposus. So if you don't remember anything else, remember that. I show you, I want to emphasize the pedicles just because that's where we place our screws. So when we put screws into the spine, we're relying on the bone of the pedicles. Again, these kind of stout pillars of bone back here to support the screws so that we can fuse the spine. And the reason why we put screws into the spine is to, for various reasons, but you can kind of imagine if you put a bunch of screws into the spine and connect them with rods, it's going to make everything very stiff. And so we do that for various reasons, and we call that a fusion. So example of a lot of pedicle screws going into the spine. Again, it looks cool, but every one of these screws is literally, potentially millimeters away from nerves and potentially spinal cord, right? So this is, again, you have to be very precise in spine surgery. You're dealing with some very kind of high stakes real estate. If you hit the spinal cord with a screw, it doesn't take much. You can paralyze that patient. Just kind of showing you again, kind of a side view of what the spine is, vertebra, disc. This is kind of showing you what happens in arthritis, right? The disc is kind of worn down. It's lost its water content. You got these little mini knee joints in the back called facet joints. And when the disc gets ruined up here, what ends up happening is these guys have to do more work, and so they actually wear down and they get what's called hypertrophic, which means they just get bigger because they're trying to take on more load. They're trying to do more work. So it's like they're going to the gym, right? They're going to the gym and getting bigger. But for the spine, that's not good because there's not much room for the nerves to begin with. So if all this stuff's getting bigger around it, it can start to pinch on nerves, and then obviously, if it becomes arthritic, it can cause pain. Oh, and then when I was talking about putting an inner body in, or like a spacer into the disc space, that's what we're doing. We're taking out this disc and we're putting a car jack device in here to kind of get the bones to ultimately kind of fuse together. So again, there's different ways to do that, but I showed you previously that you can have some big vessels up here that you're working around to put those things in. So again, you're dealing with some pretty intense structures anatomically, which makes for a exciting day, right? All the nerves are contained in what's called the spinal canal. It's the largest in the cervical spine, which is the neck, because that's where the spinal cord is, which is a direct extension of the brain. All the nerves of the body exit at each level through what's called the intervertebral foramen. Inter, meaning between, vertebral, between the vertebra, foramen, meaning obviously space. So, so that's where the nerves exit through, and they can get pinched there for various reasons. And this is kind of showing that what happens with arthritis is that you can get these bone spurs that pinch on nerves and even spinal cords. Is obviously going to be the neck, if it's spinal cord level, or even the thoracic spine or mid back has spinal cord there. But I can just tell that this is the neck based on the anatomy of the bones. So when we talk about doing like a decompression or laminectomy, you guys may have heard these terms. We do it again to free up space for the nerve elements. So again, as I was kind of talking about earlier, when you develop arthritis, these guys in the back, they try to, because they're having to do more work, they're getting hypertrophic, right? It's like they're going to the gym to work out and they're getting bigger, but there's only so much room for the spinal cord, the nerves. And so if they get too big, they start to pinch on those structures, and that can be a problem. Spinal cord's pinched, that's a really bad thing. That's one of the few times we recommend more urgent surgery. But one of the ways that we can treat that is we just kind of unroof the spinal cord. And so then the question is well, what's protecting the spine now? Well, again, you've got a lot of muscle and soft tissue back here that ultimately protects the spine. So unless you're really, I don't know, you really want to hurt somebody for some reason, and you're a mean person, and you punch somebody straight in the back back here through their muscle down to their laminectomy spine, the spinal cord is going to be well protected. So again, I'm just going to kind of briefly go through the cervical spine. The vertebrae are obviously smaller. They don't have to be as big because they're only supporting the head. And again, in the cervical spine or the neck, the spinal cord is there, and so it's a direct extension of the brain. And then the nerves of the cervical spine, as they branch out, again, through those intervertebral foramen at each level, each one of those controls a different part of the upper extremity. So for instance, if we were at, let's say, the C5-6 level or something like that, that would control your ability to feel in your thumb and kind of the outside of your forearm. It would also control like your biceps muscle and stuff like that. So each one of these nerves has a specific function. Just to kind of show you the complexity of the anatomy, and you really have to appreciate all of this. So, when you look at just a spine model, it doesn't look like much, but there's a lot of stuff going on. And again, everything is so close to one another, millimeters away from each other. Vital structures are millimeters away from each other, and all of these things do have a function. And so, again, it just makes spine surgery exciting. You have to bring your A game every day. Just another example of, the kind of incredibly, vital structures that we're kind of working around. This is what's called the vertebral artery. It supplies 10-20% of the blood supply to the brain, and we're literally working around it anytime we do any sort of neck surgery. And so if you hit that, you can potentially make a person have a stroke. And so again, another reason why you have to be very, very precise in what you're doing. And again, why I find spine surgery so exciting. A lot of muscles, they all have a function. Again, just to kind of show you the complexity of what we deal with. Thoracic spine is the mid-back. So these vertebrae are a little bit taller, they're heart-shaped. And the main difference here is that in the thoracic spine, the ribs actually attach to the spine. So your thoracic spine is probably the least mobile part of your spine for that reason, because the ribs limit motion. Lumbar vertebrae, obviously, low back, they're going to be larger, right? Because they have to support more load. So you've got the biggest bodies, they've got the biggest pedicles, so on and so forth. Again, just to kind of show you the complexity of the spine, there's a lot of nerves, there's a lot of bone elements, but there's also a lot of ligaments and stuff like that that are very important, and a lot of muscles. Just kind of want to go over specifically the neuro exam. So, when we see a patient in clinic, obviously we're going to, do what most docs do and get a good history and a general kind of do a general exam. We're not listening to hearts or anything like that in spine, but we do kind of just get a general sense of their health, and then we focus on the neuro exam. So we want to understand, if there's a nerve being pinched or something like that, what's being pinched. And, I think we have this tendency nowadays with all this technology to kind of jump to, the technology, right? So what I mean by that is, before even examining the patient, oftentimes we have this tendency to look at the X-ray or the MRI or, look at whatever tests have already been done. And, I would encourage you guys to, as you guys kind of go through your career and whatever you end up doing, whatever specialty you choose, and they're all great specialties, be a doctor first. And then, you use the tests to kind of confirm your diagnosis. So get a good history, do a good exam, and then use the imaging studies and the tests to kind of confirm what you find. As I said earlier, X-rays tend to show a lot of things that are just going to be there because the person has lived, 20, 30, 40, 50, 60 years, and they may have no pain as a result of that. So if they've got, or MRI, You know, if you got a bad looking MRI and they have no pain, you're not going to treat them, right? So it doesn't matter. So just always examine the patient first, understand what you're treating, and then confirm it with the imaging. And that's where your examination skills and history taking skills become so important. History taking meaning, you know, when you talk to the patient, you're trying to figure out what's bothering them. So again, each one of the nerves in the neck and the low back control, you know, different groups of muscles, you know, correspond with, you know, different reflexes, and so to do a good neuro exam, you want to be kind of keeping these things in mind. And you guys may have seen this before, but this is what's called a dermatomal map. So basically, the idea here is that each nerve that comes off the spine, on each side of the spine, allows us to feel in a different part of the body. And it's pretty consistent. It's pretty consistent. Now, it's not 100%. I would, you know, again, if you take anything away besides the jelly donut from this lecture or this talk or this shadowing session, just remember, not everything is by the book. So even though we've got these dermatomal maps, and you know, there's going to be people that tell you that 100% of the time, you know, when a pinched nerve is, you know, when a pinched nerve causes numbness or pain in that pinched nerve's distribution, it's going to be this distribution based on this map. That's not actually true. There's a lot of variation in anatomy between patients, so for instance, 80% of people will probably follow this map, but you know, 20% of people may not. And so again, that's why your examination skills and your kind of history skills, and again, that's why to me, spine clinic is so fascinating, because you do have to do a lot of detective work to actually figure out what's going on. There are various special tests that we can do to kind of test nerves. I'm not going to get into each one of these, but just know that they're out there. So again, being a good doctor first, getting a good history, doing a good exam is probably the most important thing that you guys should kind of focus on as you go through your training. The tests are, you know, the imaging studies and all that. It's great to understand them. You want to be good at it, but you want to be a good doctor first. All right, so I've talked a lot. This is a case that I recently got published. So I'm going to just...
In this video, we will be demonstrating our technique for a minimally invasive intradural tumor resection. Our patient was a 70-year-old female with worsening symptoms consistent.
I'm going to try to... explain a little bit of what's going on.
In this video, we will be demonstrating our technique for a minimally invasive intradural tumor resection. Our patient was a 70-year-old female with worsening symptoms consistent with cauda equina.
So cauda equina syndrome, so basically what I'm saying here is that on the exam, the neuro exam, really there wasn't much going on. So no focal deficits means there's nothing that I could really localize as being a problem. So none of the nerves, you know, none of the tests that I did were really that abnormal, but she did have, and it wasn't actually me. I actually wasn't part of her initial exam. I ended up coming on later for the actual surgery as I worked with this particular surgeon. But in any case, she did have decreased perianal sensation. That corresponds to, that's important because it corresponds to nerves being pinched kind of lower in the spine, and in particular, what it gets concerning for is something called cauda equina syndrome. Cauda equina syndrome is typically a more urgent matter to deal with, and what it means is that you have compression of all the nerves in the low back, and you know that can cause some significant problems. It can cause bowel and bladder, you know, loss of control of bowel and bladder function. And one of the ways we test for it is we ask them, or we test for perianal sensation.
Your MRI demonstrated
So this is what's called an MRI, or magnetic resonance imaging. This is what's called a sagittal image. So what we're doing is we're cutting the patient, you know, kind of in sideways slices, you know, kind of straight on slices, and we're looking at them from the side. And you can see here are the vertebral bodies, here are the discs, right? And then here's spinal cord up here, this kind of gray thing back up here. And then this should all be just kind of nerves, just kind of little strings of nerves coming down from what we call the conus medullaris, or the end of the spinal cord. These balls, these little circular things, they're not supposed to be there. So there's something going on. There's something going on with her, and that's basically what I'm trying to show here.
Circumferential masses causing stenosis at the L1-2 level.
So again, MRI image. This is what's called an axial slice. So we're kind of cutting the patient in hamburger fashion, and we're looking kind of down on the patient. Kidneys, body of the vertebral of the vertebrae. Here's the spinal canal, and this kind of large ball-shaped structure should not be here at this level. And so again, to show you just kind of the anatomy here, here's aorta, which is one of the major vessels. You hit that, patient will die. Well, not always, but it's a major problem.
The indication for this procedure was cauda syndrome with an MRI confirming localized lesions. Risks of the MIS approach are inadequate visualization and...
So again, I kind of showed you guys those tubes earlier on. Traditionally how spine surgery was done was through what's called an open approach. And so basically if you can feel kind of your spine, you'd cut straight down onto the spine. We still do this. And then basically, for lack of a better word, fillet the muscle off of the spine. So you're dealing with a big kind of, traumatic incision to ultimately get down to the spine, and then to get to the nerves and such. With an MIS or minimally invasive approach, you're doing the same type of work, but you're doing it through small tubes. So it takes a little more finesse and skill, but it does have significant benefits because, as you can imagine, if you're dealing, if you're kind of minimizing the length of the incision, you're not, filleting so much muscle off the spine. You're going to have less blood loss. That's what EVL is. You're going to have less pain postoperatively, after surgery, and patients are going to recover faster.
Adequate removal of the tumor. Benefits occurred are those commonly associated with less invasive procedures. Alternatively, a traditional open approach could be used. Standard positioning for this technique is prone on a Jackson table with a Wilson frame.
So I kind of showed you some of this. So that patient that you guys previously saw was prone. You guys don't have to worry about some of that stuff. I showed you what the C-arm fluoroscopy was. That's that intraoperative C-shaped X-ray machine. We use neuromonitoring as well. So we actually can get real-time kind of feedback of whether or not we're disturbing any nerves as we're working around them. And so there's actually, a person in the room with a little computer, and then they actually hook leads up to the patient's body and all over the place to kind of get a sense of, their nerve status. And if we, manipulate a nerve in the wrong way or spinal cord in the wrong way on accident or inadvertently, the neuromonitoring will let us know.
Draping with the help of intraoperative.
So this is how we use X-ray intraoperatively. So this is again, fluoroscopic shot using that C-arm. And basically we're trying to figure out, okay, where are we in the spine? Because again, the spine's deep and there's a lot of segments, so it's easy to get lost. And so you have to be very precise about, where you're going. And so what we've done here is we put a little needle to kind of figure out, okay, this is kind of where we're going to plan our incision to get down to where we want to be.
Fluoroscopy. An incision is made just medial to the pedicle, overlying the disc.
And then again, here's your needle, and we're shooting it straight at this area because we know that that's where that ball-shaped structure is.
Base of interest. In this case, a 22 millimeter skin incision was.
So this tube is literally 22 millimeters. So think about how small that area is that we're working through. We're just confirming that we're down where we want to be.
Made to accommodate the tube retractor system. Sequential dilation is then performed down to the lamina of interest. correct levels confirmed under fluoroscopy.
You guys will see all this coming up.
Under the operating microscope.
So what I was doing there is we've already gone through muscle. All this stuff is kind of muscle, blood, and more muscle at this point because we've cauterized any bleeders. And then what we're looking at is the spine through this tiny tube. And so you can see how easily you can get lost because it all looks the same, right? Like if you're not used to looking at the spine, all this just looks like white bone. And so again, this is why it's really important to understand your anatomy. And this is why in my head spinal surgery is so cool because if you go just millimeters in the wrong direction, you're going in a place that you may not want to be.
The landmarks are exposed with monopolar cautery. The laminotomy is made starting at the inferior edge of the cephalad lamina and carried out to the margin of the ligamentum flavum.
So what's kind of cool here is that your body actually has these almost like little bumpers for us, if you will, meaning as we drill down through the bone of the spine, in the back of the spine, you'd be worried that if you drill too deep, you're going to hit the nerves and the spinal cord and all that. And that is true. I mean, you can still do that, but your body has a natural kind of barrier between the bone and the actual spinal cord or nerve sac. And we have ligament, and then we've got some fat there. So you're going to start seeing some of that stuff.
The laminotomy can then be widened as necessary.
So what we're looking at is here's the actual nerves in the nerve sac, and then this is ligament above that. That's kind of served as a protection for us.
The base of the spinous process is then removed to perform the contralateral laminotomy. Ligamentum flavum is then removed to fully expose the thecal sac.
So now we've removed that ligament, and now we've got the nerve sac fully exposed. These are little vessels that run along what's called the dura. The dura is the outer sac, kind of protective sac of the spinal cord or nerves.
A midline dural opening is made. Preservation of the arachnoid layer minimizes initial CSF leakage, allowing for safer durotomy preparation. Tenting sutures are created using 4O Neurolon. The arachnoid matter is then opened. Using blunt dissection, the tumor is carefully isolated.
So what we're looking at here is these guys. So we've opened up obviously the spinal sac, and here's a nerve, what we call rootlet, and then you're going to see something that just doesn't look like it belongs.
Surrounding nerve rootlets. In this case, a dysfunctional nerve rootlet passing through the tumor was confirmed with triggered EMG and was subsequently transected. The freed tumor was then removed.
So that
The second tumor was then identified and removed in a similar fashion. Meticulous hemostasis was then achieved using bipolar cautery. The wound was copiously irrigated. Duragen is then placed in the intradural space.
So that's like a pig-derived, almost like skin, and we put it on the inside and around the nerve elements to kind of protect them and recreate some of that barrier that we've kind of destroyed.
To recreate the arachnoid layer. Watertight closure of the durotomy site is achieved using 4O Neurolon in interrupted and running fashion, followed by Duragen and Duracell over the durotomy site. Local anesthetic is then injected into the soft tissues.
That just helps with pain.
Hemostasis of the paraspinal muscles. Watertight closure of the muscle and fascia is performed using ovicral, followed by fluoromonocryl and dermabond for skin. Schwannomas are benign encapsulated tumors of the nerve sheath.
So this ended up being a schwannoma, which is a benign tumor, meaning it's you know, there's a big difference between benign and malignant, as you guys will learn. Malignant, you know, tumors are usually the ones that metastasize and you know, cause significant problems. Benign tumors don't really cause major problems unless they just get too big and they start to pinch on nerves, like in this case, or cause pain or something like that. You know, you can get muscle tumors and stuff like that that just get really big in the arms or the legs and press on nerves and cause pain.
There are a ton of questions throughout the whole chat. We can go through some of the recent ones.
Yeah.
So they were asking, when you removed the tumor, did you send that to the lab, or did you just, like, did you guys dispose of it, or how do you go about that?
Yeah, it's a great question. So, you know, typically when we're dealing with any sort of tumor, if we know that it's going to be a benign tumor, and you can actually, you know, off imaging, actually kind of get a sense of what, you know, a tumor is going to, whether it's going to be a benign or more of a malignant tumor, and the location of the tumor. There's things that you'll learn throughout your training that kind of help you figure out whether, you know, something's, you know, good or bad, right? And so we kind of knew going in that this was more of a benign tumor. And the point being is that because we knew it was a benign tumor, you know, we were able just to kind of resect it and send it to the lab and just confirm that indeed this was a benign tumor. If it was more of a malignant tumor, there's a different way of doing that. So oftentimes what we'll do with malignant tumors is, one, you might get a biopsy before you even do any sort of surgery, just to kind of confirm, you know, what type of, you know, kind of malignant tumor that is. And then additionally, what you might do is during surgery, you might just take a small section of that and what we call like get a frozen section of that. So you take a small section, you send it to the lab right then and there. The pathologist looks at it to kind of confirm whether or not it's a malignant or benign tumor. And the reason why that's important is that changes how you do the surgery and how you manage that patient. So in this case, you know, we knew it was benign, took it out, just sent it to the lab just to confirm. That great question.
Cool, thank you for answering that. There were some questions like early on through the presentation, then when you showed the video, do you personally work on the pediatric population? And if not, like, how many orthopedic surgeons do? Is that a separate fellowship that you have to complete?
Yeah, no, it's a great question. So throughout residency, I did do pediatric orthopedics. So I did pediatric spine surgery, I did pediatric broken bones, I did all that stuff. But typically, if you want to come out and, you know, want to work in a pediatric hospital doing, you know, just pediatric orthopedics, then you have to do a separate fellowship in pediatric orthopedics. And those guys or gals will typically, you know, even within pediatric orthopedics, focus on, you know, specific aspects of it. So some of them might do just pediatric spine. You know, some of them might do, you know, like congenital kind of deformities. So there's kids that, you know, obviously have various syndromes and they're born and, you know, unfortunately, you know, they have malformed limbs or, you know, hips that don't work right, or, you know, legs that are bent in the wrong direction. And so pediatric orthopedists would work on that. As far as spine goes, you know, if you've done pediatric spine surgery, honestly, in your training at any point, as a spine surgeon, you really can do that if you want to, just because adult spine surgery tends to be much more complex. So if you can be an adult spine surgeon, you can, for the most part, be a pediatric spine surgeon. That's a general statement. It's not you know.
Mm-hmm. Great, thank you so much. There were some questions when you were doing the tumor removal video. There were some people asking about whether the sutures that you used are dissolvable. Do you have to remove them? How does that work?
Yeah, so that's a great question. You know, the ones that we used are dissolvable. Now there are, non-dissolvable sutures that you can use, but in that video they were all dissolvable sutures. So there's really nothing to do from a patient standpoint as far as suture management. They don't have to come to clinic and get them pulled out or anything like that.
Okay, great. But also, kind of based off the tumor video, what happens when you can't remove 100% of a tumor, and how often do you see that happen?
Yeah, that's a great question. So with benign tumors, the whole purpose of kind of getting rid of that tumor, particularly in this case, was just to kind of take the pressure off the nerve. And so as long as you remove most of it, you should be okay. Now, there are instances, both in the spine and in the extremities, where you just can't remove all the tumor because, it's wrapping up a major vessel or something like that. And so you kind of have to weigh the risks of, if it's a malignant tumor, you obviously can't leave it, right? Because it'll continue to grow and it can metastasize, meaning it can go other places. And those are the bad tumors. We don't want to leave those alone. So if you have a malignant tumor that's wrapping up like a vessel that's vital, you may have to take that vessel. If it's a more of a benign tumor, you can kind of do what's more of like a debulking. Let's say the benign tumor is wrapping up a vessel. It's huge, and you're able to remove most of it, but there's part of it wrapping up a vessel, and you want to save that, limb, or maybe in the spine, you're trying to save, some element of the spinal cord or some nerves. You may leave it in that instance. So it really depends on what kind of tumor you're dealing with. But that's a great question.
Thank you. There was an interesting question asking if you could talk more about the financial exclusivity of spine surgery. Do you tend to see patients who are more financially privileged? Do you think expensive equipment and technology makes spinal surgery even less accessible for people who can't afford it? And what's the protocol in those situations?
That's a really forward-thinking question. I love it. Yeah, so I mean, you're gonna, if you require spine surgery, you're gonna be able to fit it somewhere. So there's different insurance plans that that cover that. And as far as, excuse me one second, I'm getting out of the car, so just give me 1 minute here, and then I'll start talking again. Thanks. Yeah, thanks so much. I'm just gonna set up over here. Hey, thank you. Have a good one. Thanks. Did I get everything, or? Yeah. Okay. Do you have my phone in there? It's in my bag. No, it's right here. It's right here. Good. Yeah. Thank you. Sorry, guys. So let me just start over. I was a little distracted. So the answer to the question is, it really depends on kind of where you are in the country. So and what the demographic of the region or area that you're treating or working within is like. So for instance, if you're like in Beverly Hills, where I spend some of my time right now, you're going to be dealing with a lot more affluent people that have a lot of money. But that being said, you go to a place where maybe there aren't as many financially privileged people. There's still going to be docs there. There's still going to be spine surgeons there, and they should still be able to get most of the spine surgeries that are considered standard of care. So what I mean by that is, if you got a pinched nerve, or significant back pain, or spinal cord's being pinched, and clearly there's a major issue, that's considered standard of care to be able to offer that that patient spine surgery, regardless of what their insurance is. Now, so bottom line is, if a patient has a spine problem, they're going to be able to find care somewhere. Just given the fact that there's various kind of insurance plans out there, Medicare, Medicaid. Now, if they're uninsured, that obviously can become a problem. But like, for instance, like what we call more like truly elective spine surgeries, like there's technologies out nowadays to replace discs, and kind of more newer technologies that aren't necessarily 100% proven. Those insurance isn't going to approve, and so the patient, only patients that really have money may be able to afford those. This is obviously a kind of a 30,000 foot view of kind of how it works, but hopefully that answers the question.
Yeah, that was a very informative answer. Thank you. And I guess our last question that we have for you is, first of all, everyone's thanking you so much, and thank you for staying a little over.
Yeah.
What final advice would you give us pre-med students, especially now during COVID?
Yeah, I think keep doing what you're doing. Try to find the opportunities to get the experience that you guys want, that you guys need. Keep working hard, to make yourself the most impressive, future applicant you can make yourself. I would say probably my best advice in general is never take what any single person says as gospel. Okay, so it doesn't matter how impressive this person is, what their credentials are. If somebody tells you one thing, always get a second opinion, always get a third opinion. And at the end of the day, only you know yourself. And the reason why I say this is that I had a lot of people tell me with the grades that I had, or as a DO trying to go into competitive, trying to get a very competitive orthopedic spot, that it wasn't possible because of where I was coming from, the grades that I had, just because historically maybe it hadn't been done. But I still worked hard, and I kept persevering, and I kept asking around, to people who had actually done these things, and they're out there, and that kind of kept me going, and so I'm here now, right? So I was able to get where I'm at. Despite people telling me along the way that maybe it wasn't possible. So I guess, only you know yourself. Always ask for kind of additional opinions, and, just keep doing what you're doing.
Thank you so much for that advice. People are saying that you're very inspirational and that they loved your presentation. It was one of the best that they've ever seen. So thank you so much for your time today.
Hey, anytime. Thanks for putting this together.
Yeah, of course. And if you guys want to go ahead and follow Dr. Chung on Instagram, his Instagram handle is on the slide right there. So yeah, thank you so much, Dr. Chung. We hope you have a great rest of your weekend.